My role is to call us all back together again. And as we are taking our seats, I want to give Paula another round of applause and thank her for lifting up the Wisconsin Cancer Plan and linking it to the other work that's going on in Wisconsin. So our next session is about data in Wisconsin. We'll learn about sources of Wisconsin cancer control data, including social determinants of health, how to find them, how to access them, and how to use them. Panel members will discuss our existing data, strengths, and weaknesses, and we'll all continue to look at the data to help inform us on our programming and evaluation activities. We'll continue to listen to case studies from a WCC partner who has put data into action. For this session, please help me welcome David Frazier. David is the director of the Center for Urban Population Health at the University of Wisconsin-Milwaukee. Initiated in 2001, the center is made up of faculty and staff from University of Wisconsin School of Medicine and Public Health, UW-Milwaukee, and Aurora Research Institute. They work to advance population health research and education to improve the health of urban communities. Welcome, David.
Good morning, everyone. I'm David Frazier. I'm not a Paula. I apologize. I was thinking about Paula. I've been seeing you a long time, and I think the first time you met, you actually were working on the ACS breast cancer focus group project. The maybe Gail funded, I don't know, or both. One of the two funds at the time. So it's great to see you, and thank you for bringing it full circle. Our center is really, our tagline is evidence-based, data-driven, community engaged. And I came into this through the community side, but I really geek out with data, so I'm excited about this panel this morning. As I introduced everyone, I kind of gave them a heads up. The community side of me is going to come in. If you know me, which many do, it's good to see you all. I have another icebreaker question for them.
Oh.
So let's get started. Our first session this morning will be with Lena Swander. She's been an epidemiologist with the Division of Public Health since 2017. She currently supports cancer surveillance with the Wisconsin Cancer Reporting System and is passionate about responsible, equity-focused public health data visualization and interpretation. She coordinates the Milwaukee Cancer Reporting System's data request and research portfolio of over 150 active projects. My question to you, I'm not suggesting that you went trick-or-treating, but if you would have, what costume would you have worn?
Well, I told you an answer, David. I'm going to change it. I love when people show up in big boxes, just like they've reused something that a package is delivered in, like a big calculator that just takes up a lot of space. I think those are good. Also not a Paula. Just gonna test this out. Remove them. Cool. Yeah, I'm Lena Swander, epidemiologist with the Wisconsin Cancer Reporting System. We're located at the Department of Health Services in Madison. Just out of curiosity, could I get a quick hand raise? Who's heard of WCRS or the Wisconsin Cancer Reporting System? Ooh. And for those that haven't heard of us, we're a central cancer registry for Wisconsin. And I'm going to talk a little bit about us today. And how you can connect with us, and we can connect with you. So the short version of what we do is that we collect, store, and manage data on persons in Wisconsin with cancer. We've been around since about 1976, established by state statute. And we publish official statistics on newly diagnosed cancers and cancer mortality in Wisconsin. So a common question we get at the registry is, how does a cancer diagnosis become a statistic? And so we're gonna kind of walk through a journey of a patient, I guess just wanting to recognize that this could be your own story. This could be the story of loved ones or family in your life. So just appreciate you walking through this with us today. So a woman in Wisconsin goes in for a routine mammogram. She gets an X-ray and a needle biopsy to confirm that she has a cancerous tumor about the size of a large pea in her breast. And she ends up getting surgery at a hospital to remove that tumor and also receives chemotherapy treatments. Before the surgery and the chemo, she gives information to the physicians on staff, the other medical staff, things like her age, race, ethnicity, even the name of her health insurance company. The doctors take all that information down, including information about the tumor itself, where it was located, some diagnostic information on it, how big it was, what they did to treat it. And in our example, the hospital that this woman is at and was diagnosed and treated at has its own cancer registry within the hospital. And a specially trained person called a cancer registrar looks at all of the information in the medical record and about the cancer, the treatment, puts it into a computer system using special codes. And the registrar also makes sure that none of the information that we need is missing. And then that information gets sent to us. This is actually an old postcard image of One West Bolton. It was in our stockpiles. I love it, but just to give you a sense of what our building looks like and where we sit. That information comes to us at the Wisconsin Cancer Reporting System, and we do our best to get information on every diagnosed cancer case in the state. We review a lot of information that's coming in all the time, perform a lot of day-to-day management tasks on that incoming data. And every year our data are frozen. So annually we freeze the data in a database so that we can publish official statistics on it for every year, and that the information remains consistent. So our data come to us as abstracted cancer cases from that example, as you saw, and our staff use software suites to process, edit, and consolidate incoming data. And this photo is not meant to scare you. You're not supposed to see it, but we have a lot of steps that we take to process information. The example we gave is kind of a case where information is coming just from a single hospital, but we do process pathology labs and everything, and it all gets consolidated down and again frozen into our database annually. I also am using this image as a way to kind of demonstrate the complexity of incoming data and to kind of highlight here the cycle that we work on. A common question we get at the registry is, why is there such a long data lag? Why does it take 2 years for your data to be frozen? And some of it has to do with lengthy treatments, and we want to collect complete information on a case. Some of that has to do with it's just a lot of complexity, and we have to run on a certain cycle. So we try to make, we follow certain national standard setters, and we try to make the most high quality data available to you. So right now we've got 1995 to 2020, and in January we will have through 2021 available for request. So some of the data that get reported to us, we get information on patient demographics. So this includes information that identifies the cancer patient, such as name, age, gender, race, ethnicity, birthplace. We also collect information on the stage of the disease. This describes the extent of the cancer, such as how far it has spread. This kind of informs whether cancer has been diagnosed early or late and what treatment plans should be considered. We collect outcome information. This would be information like the patient's vital status or the cause of death, and we can use this information to estimate survival time of patients. We have information on tumor cancer characteristics, so these are things that describe the tumor cell type, biological and clinical aspects of the malignancy, such as what organ the cancer started in, and now some genomic information on the tumor. We also collect treatment information, so this collects first treatment information, such as surgery, radiation therapy, chemotherapy, hormone therapy, immunotherapy. Just wanted to highlight some of the common questions we get asked, some things that you can use our data for to answer. So we can ask questions of this data like what types of cancers are increasing or decreasing in Wisconsin. We can ask things like who is most likely to get a certain type of cancer in Wisconsin. We can also get a little bit more complex. Is there a certain part of Wisconsin where women are finding out they have breast cancer at a late stage where it's harder to treat? And just a little plug for those of you who haven't seen the Reducing Breast Cancer Disparities publication yet on the Cancer Collaborative site, please take a look at that. Some of the images that Paula highlighted about disparities between Black and white women and breast cancer are from that report and highlight our data. Also, what kind of questions can't cancer registry data answer? Just one example here. What percentage of people in Wisconsin were screened for colon cancer in 2023? We don't collect screening information. We do have some of that information available from other data sources at the Division of Public Health, but the registry data doesn't have screening estimates. Just wanted to highlight for all the local health departments and other folks who might be looking where can you get data that's readily available from the registry. We do support free and online public portals. Just going to highlight a top few here. WISH, or the Wisconsin Interactive Statistics on Health system, is I don't know how many modules long. There's a lot of modules featuring lots of data sources from the division. We have, I think, a total of 4 for the registry. If you have any questions about that, there'll be contact information here. The Environmental Public Health Tracking Portal, I think, posts about 17 different types of cancer incidence rates by county over time. We provide registry information for that portal. Also wanted to highlight the Wisconsin Cancer Collaborative's county cancer profiles, which have a host of other information on it, but also have some incidence estimates from us, mortality estimates from us. And then cancerrates.info is a website hosted by University of Kentucky, and we have been providing them annual data for a long time now. And then the fun interactive part, if you wanted to explore any of those right now or during the conference, I'll just leave this up for a second. You can scan the QR code, which will take you to our registry's website, highlights all of those free online portals. And that's the website itself. Phones down in the back. And we also support cancer prevention control research with our data. Since about 2016, over 100 data requests and research studies have been supported by us. Just wanted to shout out to some of our staff in the room. I have only been with the registry for a few months, so they've done most of this work. But we've been supporting a lot of research and studies. WCRS data are governed by regulations, policies, and laws to protect the privacy, confidentiality of patients, healthcare professionals, and healthcare facilities. And this means that we only release our data for IRB approved research. If you request data to us and you're not a researcher, we can release it, but there are suppression criteria that we have to follow. And you may or may not get to interact with the data governance board, and I'll help you through that. So. If you want to learn more about requesting our data, another QR code or the shared inbox for our cancer registry. Monitored by all of us. We love to hear from you, partner with you for lots of things. So that's it for me.
Thank you. I've worked with them for many years. It's been very easy. The board's not scary. I don't know. We're going to take all the questions at the end, so please jot them down. if you have them heard, and I have some when we get there. So our next topic is around social determinants of health. And Chelsea Robinson is a social determinants of health epidemiologist at the Office of Policy and Practice Alignment, otherwise known as OPA, in the Division of Public Health in Wisconsin Department of Health Services. Her focus is on collecting and analyzing and integrating social determinants of health data into public practice. She has previously experienced as working as a health worker.
Good morning, everyone. I'm Chelsea. I use she, her pronouns. Can you hear me okay? Cool. I'm happy to be able to talk a little bit about some of the work we've been doing in the Division of Public Health around social determinants of health data, which I think is a great follow-up to some of what Paula talked about this morning as well. So I only have a few minutes, so I'll try to keep this brief, but I'm just going to quickly define how we talk about social determinants of health. And then I'm going to talk about how we can use data on social determinants of health to tell better stories in public health, and how we can layer this type of data with the other types of health outcome data, like what Lena talked about as well. And then I'll discuss a few efforts we have currently underway to improve the infrastructure around social determinants of health data. So the World Health Organization defines social determinants of health as those non-medical factors that influence health. So we're not talking directly about things like, did you go to the doctor and do you take your medicine? But we're also talking about those conditions where people are born, grow, live, work, and age. But it's not enough to only look at those conditions where we live. We also need to look at the wider set of forces and systems that shape those conditions. So it's one thing to acknowledge that a patient who is housing insecure is going to have a really hard time keeping up with their medication regimens. We also need to acknowledge, why is that patient housing insecure? Is it a bigger issue in the community? Why is this an issue in this community and not a different community? And what social norms, economic policies, and development agendas have led to those inequities? So many of you have probably seen this before. This is the county health rankings model, which really does a great job of summarizing the relative impact of social determinants of health on health outcomes. So near the bottom of this image, you'll see the physical environment factors, things like housing, transit, air and quality, and then social and economic factors like education, employment, income, social support, safety. These items collectively explain around 50% of health outcomes. So while looking at things like health behaviors and access to clinical care are certainly really important towards promoting long and healthy lives, we also need to look at these upstream or more root causes of health as well. And sometimes this is an area where in public health, we're kind of newer to telling this story. We have some great data collection systems on things like health behaviors and health outcomes in clinical care. And we're sort of newer to adding this other layer of context around what are these community conditions that are impacting health. And in public health, we often rely on data for telling our stories. There's data and research supporting the work that we do. And when I say data, I really mean a comprehensive view of data. Not only numbers and statistics, but also community conversations, focus groups, community insights, interviews inform the work that we do. And it's really hard to incorporate that knowledge around social determinants of health and what is leading to these health inequities if we don't also collect data on social determinants of health as well. So, as many of you probably know, if you've tried to find data on social determinants of health that are relevant to the area you're working in, it's kind of challenging. We don't have a lot of infrastructure there. And in the Division of Public Health, I think of our work as having kind of two arms to meet this need, especially as it relates to some of the work we've been doing around state health assessment and state health improvement planning. The first is we've been working to develop a comprehensive list of social determinants of health data indicators that can help us tell the story. So what we've found is there is a lot of data out there on things like housing and economics and education, but these items often lie outside of the traditional field of public health, and we need to draw on the experts from other disciplines to glean this information that can inform our work today. So we've been working to kind of meet with these other experts and create this comprehensive database of secondary data that already exists, that is at a geographically specific level, and we're trying to keep track of what information can be available by 4 different demographic subgroups. So some indicators that might be relevant to look at for a certain age group or for certain race or ethnicity as well. And then based on all of this information, which there's been a lot, so we're still working through it, we know that there's still not information on everything we want to look at. So our second kind of aim is to increase collection around social determinants of health data. And I'll talk a bit about some of the early efforts we're working on there as well. So touching on that first goal quickly again, we currently have formed a list of about 158 social determinants of health indicators based on the secondary data collection. We found data across a lot of different subsections, which you can see listed here. I won't go into too much detail. But this is not a complete project, still kind of early to middle phases. Right now we're working on engaging with some partners to get feedback. What are we missing? Making sure we're interpreting data correctly, talking with those experts in the field before we can get this finalized. And we welcome any of your input on that as well. And then in the future state, we would like to have some more curated data sets and visualizations to help tell the story more broadly about how social determinants of health are fundamental to health equity. We're also in the works of developing some additional trainings and toolkits to kind of break down how we can leverage this type of data in public health to add that extra layer and context to the work that we're doing. And then, as always, we plan to keep this up to date and continuously improve as well. Often, this type of work, drawing on secondary data, we see to be most useful for folks who might be writing a grant application or doing some sort of assessment or plan and want to just pull a number and place it in the report. So maybe it's relevant for you to look at the percent of households that are cost burdened in your community. From a database like this, you would be able to find that data and then place it in your report. The second goal is to increase collection of social determinants of health data, specifically targeted at items that we can't find anywhere else. And in 2022, we've had some success about adding social determinants of health questions to some of our public health surveillance systems, like the Behavioral Risk Factor Survey and the Family Health Survey. And our colleagues in the Office of Health Informatics have been a huge support in this work and have been fundamental to the success here. So this is really exciting for a few reasons. One, if we have questions about social determinants of health in the same data systems that we have questions about things like, did you get your cancer screening, or did you receive a diagnosis of this certain health outcome? We can do more sophisticated analyses and answer more critical questions about what creates these health outcomes specifically. You can see a few examples of questions we've been able to add to these surveys starting in 2022. So we'll have data on that really any day now. And we were also able to add paid sick leave access questions to Family Health Survey in 2022, which is another really important and critical data point that we just don't have access on right now for the state of Wisconsin. So I'm really excited to get this data as well. And like I mentioned before, when we have this data integrated into these other survey systems, we can do more sophisticated analyses. So maybe based on your insights working with your community, you want to look at the percent of folks with cancer who are food insecure. We can look at that if we have questions about those two things in the same data collection system. So we could answer more complicated research questions and conduct association analyses to paint this bigger picture about what creates health. So I know I talk a lot and it can be a little overwhelming sometimes. I like to end on this slide. No matter really what type of work you do, there's always room to take a step back and think about what are these root causes and or these social determinants of health that are critical to the work that you're doing. This is often apparent when we talk to the folks on the ground, the people experiencing these health outcomes. We can leverage these qualitative insights to inform what social determinants of health are most important to this issue. Often you don't need as much data as you think. A couple meaningful indicators can help lift up that community voice and allow you to track progress over time. And then from there, we always like to double check and make sure that the story we've created still resonates with the communities that we're serving. So happy to take any questions at the end. Thank you all.
Thank you, Chelsea. I forgot to ask you your question. Sorry. You thought you were going to.
Is this working? My friends always create some sort of boy costume for me based on having red hair. So if there is any pop culture character that has red hair, it has probably been a Halloween costume throughout my life.
Thank you. Our next presenter, Korina Henningsen, is an assistant director at the Neighborhood Health Partnership Program, NHP, at the University of Wisconsin School of Medicine and Public Health. Through a partnership with the Wisconsin Collaborative Healthcare Quality, NHP provides neighborhood health reports at a zip code level using electronic health record data. These reports, along with our social demographic reports and action tools, support a wide range of stakeholders in better understanding the health of the communities and targeting health improvement initiatives. Please welcome.
Good morning. I'm excited to be with you today and share some of the resources that the Neighborhood Health Partnerships Program, or NHP, has available to you all in your work. So starting with a common challenge in using data, we know that health is greatly shaped by local conditions due to policies, systems, and environmental factors. But oftentimes, health outcome and care data is only available at the county level or higher, which can make it challenging to identify priority areas and monitor the effectiveness of programs and interventions. So the opportunity that we have with, in partnership with the Wisconsin Collaborative for Healthcare Quality, using their electronic health record data from health systems to create neighborhood health reports at the zip code level. For those unfamiliar with WCHQ, they're a voluntary consortium of health systems throughout the state who voluntarily submit their electronic health record data from primary care visits for public reporting and quality improvement purposes. And they have EHR data for over 75% of primary care providers in the state. And they have 27 health outcome and care measures identically coded across health systems, spanning the care continuum from vaccinations and wellness measures to screenings and chronic disease care. And of particular interest to this group would be HPV vaccination, breast, cervical, and colorectal cancer screening measures. So this slide is just an overview of the NHP resources available. First, we have maps, geocoding the EHR data at the zip code level to help in selecting measures or zip codes of interest to identify where you might like to request neighborhood health reports for. And then we have two main categories of reports. First is the health outcome and care reports, and those use the electronic health record data for those 27 measures that were on the previous slide. And then we also have developed, in response to stakeholder feedback, social determinants of health reports, because report users wanted more context about communities. So these reports use just US Census American Community Survey data and present data on the living conditions and the zip code compared to county and state averages and other rural or urban zips. And those SDOH reports include measures from the physical environment, economic and work environment, service and social environment. And then to help report users use data for action, We developed a suite of action tools that are just available on our website. Anyone can access them. We have some focus on evidence-based strategies to improve health for these measures. A tool around building and enhancing partnerships, as well as using data in the policymaking process. And then our newest reports are, our newest action tools are helping connect our social determinants of health measures to health outcomes. And our latest one that we just released is on cancer screening. And all of our reports and tools are freely available at no cost. This map is an example of our coverage for the state for 2022 data. So this is colorectal cancer screening in Wisconsin. The lightest blue zips are highest performing quartile in the state, down to the darkest blue, lowest performing quartile in the state. Any areas in gray, we do not have sufficient coverage, but any zips in blue, you would be able to request a report for. And then to just quickly walk through a sample report. This is page 1 for colorectal cancer screening. So we have maps showing the zip code and county and state, and then the measure definition. So how this colorectal cancer screening is measured. In this case, adults age 50 to 75 who've been recently seen in primary care. And then we have who met the measure. So those estimated to live in the zip code who would be eligible for that measure in the first circle. The second circle is of those who is included in this report. And then of those individuals who met the measure, so who was screened for colorectal cancer. And then a brief blurb about the importance of the measure. And then page 2, and the first blue bar shows the zip code performance on the measure for colorectal cancer screening. And then the next 2 bars are the county benchmarks. So the second is the county average, and then the highest performing zip in the county. And then the state benchmarks are the bottom 2 bars, the state average, and then the highest performing zip code in the state. So you can see how the zip code compares to county and state. And then we have a graph of how the measures changed over time. And then the next page, we have just information about who is living in the zip code. So you can compare the population in the report to the census population. So we have percent female, percent age 65 and over, and percent uninsured. And then the race and ethnicity breakdowns of those individuals included in the report compared to census data. We also have some questions about social determinants of health and considering what else might be impacting health in this neighborhood. So just an overview of our process. Our data and reports are available through a request form on our website, but they are available at no cost. And then our action tools are freely available on our website. And then when you request a report, it is delivered by an NHP navigator who is trained on the data and can help you interpret the data, make connections. And then we really want these reports to be used by a wide variety of stakeholders, including health systems and clinics, community-based organizations, local public health, and pharmacies. So to develop these reports, we conducted co-design sessions with a lot of these stakeholders to design the report and improve them over time. And they can be used for a variety of functions, such as better identifying and targeting disparities, using them for grant applications, directing services and resources, establishing new partnerships at a local level, and then with regularly updated data, monitoring and evaluating over time. So to request NHP reports, you'll just visit our website, nhp.wis.edu, on our reports page. There you can view example reports, and see frequently asked questions and other resources. And then when you're ready to request reports, you can, click request a report, fill out a brief Qualtrics form, and reports are typically delivered in 2 to 3 business days. And that's for both our health outcome and care reports and our social determinants of health reports. And then for any custom data needs, we can also deliver data in spreadsheet format, such as for grant applications. So you can get in touch with us if you need data in spreadsheet form, or for a whole county or multiple counties or things like that. That would be better served in spreadsheet form. And then to share some NHP plans for the year ahead. So the data we currently have available is from 2018, and this year we'll be updating to 2022. And then the health systems are post-pandemic are regularly submitting data every 6 months. So we hope to update every 6 to 9 months, so you can look at trends over time. We're also extending NHP data to bordering states where our health systems have service area as well. And then we're excited to add a 16th Street Community Health Center data in addition to Access Community Health Center in Madison, to help improve our coverage of underserved communities in the state. That's one limitation I want to note is, aside from those two, we don't have community health center data or Indian Health Service or tribal clinic data in at this time. And then I just want to acknowledge our sponsors and partners over time. And then this is our website to request reports, and our email for contact information. And I'll also be at an exhibitor table outside if you have any questions, want to use some sample reports, or discuss your data needs. Thank you.
Thank you, Korina. And your costume?
I did not trick or treat this year because we were out of town for a wedding. But last year, my fiance and I were Mary Poppins and Bert. It was one of the cheapest costumes to put together that I've ever done. It was popular.
All right, so ask for pictures, which she's over to. Thank you. Our last talk today is going to be from Cami. No. Buchmann, thank you, Cami. A community health specialist with the Oneida County Health Department. Cami works primarily with community health assessments and community health improvement plans. For a portion of her department, creating, researching, and collaborating with community partners. Please welcome Cami.
Hello, everybody. I would just like to preface this whole conversation that we're having is that I am not a public health speaker. I am not very good at talking in front of crowds, so my heart is racing right now. So please be patient with me as I try to present to you today. With that being said, I am very grateful to be here today and sit among these wonderful panelists. There are so many good things that we have been talking to you all about today. So to build off of all of that, my name is Cami. I am a community health specialist at the Oneida County Health Department, and like I was introduced, I do a lot of work in data. And I could probably spend a lot of time today talking to you about data, but we're going to try and shift it into more of a local public health look. So this is our timeline that we have for Oneida County Health Department. It is just a very brief overview of our community health assessment process. This is kind of a way that we do to gather information from our community to assess the needs in it. So as you can see, we started way back in November of 2022 when we did our first primary data collection with our survey. And then we are still moving forward, and in today's, we are in October for right now. Currently, we are working with our coalition members, we are working with our community members, and I am currently in the process of collecting actually more data for the request of our community members to see what other things might be needed to be addressed in our community. So with that being said, how do we use this data in local health departments? So
we were very fortunate enough to have a framework that we currently use right now and will probably continue to use in the future. Is Healthy People 2030. It is a large framework that contains 5 key areas to address community needs and improve the health and well-being. So those include some of the ones that we've already been talking about today, and that is economic stability, education access and quality, healthcare access and quality, neighborhood built environments, and social and community context. We've used many of these frameworks, data, how do they call them? I think they're data core measures. We've used them. They are a very, very long list of just measures. So they can range anywhere from, we have talked about cost burden to education to the amount of kids who smoke to the percent of people who get screened for things. But they contain a lot, somewhere in the range of 358. So we have been using their framework as a guidance of what data we should be collecting for our community. And it's very hard to tell what data to collect just because there is so much data out there. But using this framework, we are able to kind of have a launch off. So with that being said, now please don't be overwhelmed. We converted all of their core measures into an Excel sheet, hyperlinked it to the website to view their measures since it is a national measure rate, and put in our own data. So I went to a lot of different websites to collect all of this data, starting with the indicator itself, then the measure that the Health People 2030 have, in addition to the year the data was collected, and then county data for our own county, Oneida, and then as well as our partner counties, which are Forest and Panelists. So not only did I just do ours, we had 2 other counties that we also accommodated. So then we also, in this sheet, we included the source of where you could collect this data, and then the link directly to it. So that way you don't have to worry about trying to find it every single year, because as a struggle in the local health department section, it's hard to collect all this data and then the next 5 years when you come back to do this initial assessment, figure out where you went or how much the data has changed. So we just collected this and put it into an Excel sheet. So I'm very proud to say that we have finished it and published it on our website. It is completely done and updated. Now, with that being said, it is not a very what is it called, static document. It is a very living thing. It is changed and updated all the time. We are currently working on finding ways to update it in a way that can be used for everybody. So this is publicly accessible to anybody who would like to see it or use it. The data can be found on our health department website underneath our CHA health assessment button. So if you need to find any of this data or are curious about this stuff that we've collected, it is on our website to be viewed, along with all of the other stuff that we are doing right now. So with that, we collected over 352 pieces of select data, and it seems like a lot. It is, but there's actually that number has grown since this presentation. I recently talked about this last time, I think in November of last year. I want to say November of last year. I can be very wrong. But that number has very much grown since we've had our community conversations and have had community members request more data in our community. So I guess that the tips and tricks that I would have for anybody who would be looking at data is that there's a lot. Don't let it try to get overwhelming. Be specific in what you're looking for and utilize your partners. We outreached a lot to many different departments and organizations to help us with our data collection. Many public health local departments are not fortunate enough to have somebody specifically dedicated to this data collection process. So utilizing what you have and not reinventing the wheel is very important for us. But I'd like to take a moment to also address that secondary data is a very important thing. But not only that, primary data is also very important. We've talked about sometimes having data that's not all the way updated and may take a couple of years to get updated. So we took the initiative to go out to our community members and hold focus groups, key informant interviews, and community conversations to hear the voices of these issues that are actually going on in our community right now, rather than looking back at this data from past time. And not to say that secondary data is not the best, because I love it. It is very important. It shows us that trend over time. But if we're not keeping up to date with what's going on currently in our community, it's kind of easy to get blinded by the past and see, well, if it's continuing to go up, it's probably going to continue to go up. When in all reality, maybe some measures have actually stabilized out or gone down. So these are just a few of the primary data findings that we had in our community. So we had a lot of people address that childcare, housing, transportation, access to care, and just overall good economics is a very important topic right now in our community. And that is something we are currently trying to address. So I guess the next thing I'll be talking about today is that how do we use that to tailor to the needs of our community? So we used this whole secondary data packet, that Excel sheet that was shown to you as a starting point. It was then given to our steering committee members to sift through. We had a lot to do to go through, over 100 and some pages. And they were to go through and select kind of like what highlighted to, or what stood out to them, what was kind of highlighting their experiences, people they worked with, what did they see in our community. And after they went through, they gave us back the data, and it was my job to then create posters, kind of telling the story of like, what did we hear from our secondary data? What did we hear from our community conversation participants? What did we hear from our just overall members of our community? We developed these posters then that continued to show this story, and it includes quotes from our community that are very relative to that area of topic. And then also includes secondary data and other primary data that we collected throughout that year. So we hosted actually 30 community conversations to help address the needs in our community. So with our data collection being so large, we opted to have our community members choose the priorities of their community, because sometimes it's hard to be a local health department and just choose one specific area when there are very many multiple areas of health that we should be focusing on. So we turned it over to our community and we let them choose. We then, for our first community conversation, we actually brought together community partners and other just local community members that represent a very wide variety of our population in our community to analyze these primary and secondary data, and then to choose these primary or preliminary health priority areas. We then asked everyone to come back, where we then finalized our health priority areas and chose very specific key indicators within those areas. So for example, and we'll be looking at this in a little bit, but one of our areas was substance use. We specifically identified that youth substance use was a very important area, but people wanted to dive down deeper. So we actually went further than that. So I think that we eventually got around, yeah, I'm blinking, I'm not gonna remember that. Moving on. Anyway, we used those specific health indicators to then go on to our third community conversation, which is our improvement planning, kind of our action, what our moving next steps are gonna be. And these were making those logic models and identifying strategies that we can actually do on ground level right now to help with our community. So if you'd like, there are a whole bunch of reviewed information on this slide. It's also on our website, like I've said, of the recaps of stuff that we did. So with that being said, it's very important to not only use the information you have, but to also put actions into steps. So we actually used, and we were fortunate enough to have a facilitator who works very well and is very smart in this aspect. She works with CATCA, and that is creating an effective community change. And she introduced us to these 7 strategies, kind of a way to assist coalitions and groups with identifying appropriate and timely action steps, and include a comprehensive action plan for strategy and intervention and implementation. So we had providing information, enhancing skills, providing support, access and barriers, incentives and disincentives, physical design, and policies. So in our conversations, we actually went with our community members and we walked through the steps of creating a logic model. They identified the problem. In this case, we identified that Oneida County adults are at risk for developing unhealthy drinking habits. And you can see below that we have data supporting that, saying that 28% of Oneida County residents report binge drinking or at least heavy drinking. So then we asked, well, what's actually going to be a root cause of this? So after further brainstorming techniques, we finally discovered that community norms or this drinking culture is more of an acceptable thing than we thought of. And then we also identified that access to drinking is also very easily available in our county. So after identifying those root causes, we were like, well, that's great, that's wonderful, but how does that specifically address the things in our community? Which then leads us into our local conditions, which are very, very specific items in our community that we see. So like them listed on the screen above, we have some of the adults are consuming alcohol at youth events. And there's the data next to it. Some of these are going to be TBA or to be determined, just because we don't have measures for it. Like no one's collected data on this before, which is okay. We are now changing in a world where we're looking more at the social determinants of health. So I guess this next part is like, where are we going next with our community? So you can see now the rest of them are more related specifically to our community. But after we developed that logic model in our community conversations, we then asked them, well, let's take one of those local conditions and let's really brainstorm. Let's really dig deep to see what we could do about it. And so we chose adults are drinking alcohol in locations where children and family events are taking place. So we asked them, like, well, what can we do to reduce this? What can we do to help our community decrease this behavior? And we selected these items and or at least brainstormed them. And so you can read them here. I won't go through all of them. It is very long, but this is actually a very good process. We plan to go through many of our local conditions this way to help identify these strategies and how we can effectively help our community members in addressing these issues. So we currently right now are working with our other coalition members in all of our health areas, specifically to work to address the health priority areas that were selected in our community conversations. Some of those were health, mental health, substance use, housing, and childcare. So currently we're working with them to do all those things and make these logic models and identify these strategies. So with that being said, I'd like to thank you for your time today.
So, you're always council? Oh, yeah.
I was hoping maybe you'd forget. This year I did not go trick or treating just because I don't know about any of you, but we got snow on last snow, so it was way too cold to go trick or treating. But I was fortunate enough. I helped coach a learn skate program for figure skating, and I helped run the program. So we had some kids who decided not to go trick or treating this year, and I decided to dress up as Belle and be a Disney on Ice character and help train the kids.
Fantastic. Thank you. Thank you all for sharing. I know you all have mounds of data behind you, but it's clear that you're also trying to get it more accessible, transparent, and available to all of us. So as you're gathering your questions, we have one question for everyone we'll start with. As members of the Wisconsin Cancer Collaborative, how can our member organizations work with you to help address some of the data gaps that you experience in the communities that they serve? So thinking about all the members and all that we do in the room, are there gaps that we can help fill that you see in your data?
Start off, I would just say that for a few of our like public health surveys, the Division of Public Health, we do have an opportunity every year where we can propose additions to be added to those surveys, like the behavioral risk factor survey and family health survey. there are a lot of requirements and some different things, like there's a proposal to fill out, but if there is a data point you know you need or that you know would benefit the communities, you can reach out to me and I can get you in contact with the folks and we can work on filling out the proposals or seeing if there might be other data sources that could fit those needs. Yeah, happy to answer any questions there as well.
I think for our data source, again, always looking for additional health systems or clinics that want to participate. So if you have relationships with any of those health systems, especially in the parts of the map that I showed that are grayed out, working with them, talking to them about the value of this kind of data at a local level.
So from the cancer registry perspective, I mean, from the long SDOH map that, Colin and the others had up where health outcomes are at the end, that's where we sit, the registry. I mean, we have, incidence data and mortality data on cancers that's very standardized and very high quality. But we need the Cancer Collaborative and its members, for every other part, the upstream part, the connections with the community to understand what types of questions, to ask with our health outcome data. So, yeah, I think the biggest gap for us is, just knowing the direction from the community and what to ask of our data. So, we're relying on all of you.
I guess I have one personal follow-up for your presentation too. What happens if someone changes treatment providers, changes health systems? How does that get handled?
Oh, John, we still get it, yeah. I guess I don't know how much detail to go into about, I guess, consolidation of a record. But we have lovely certified tumor registrars and our data quality, specialists in the audience too. We do get the abstracted data if somebody changes providers. It gets consolidated down.
Other questions for the group, for the panel? Right, yeah.
Good afternoon, or good morning, I guess it's still is. Cami, this question is for you. The information that you collect on adults drinking at children's events. My question is, do you break the children down by age? Are we looking at, maybe elementary school children? Are we looking at preteens or teens? So is it broken down by the age of the children?
That is a very good question. Like I said, we identified these areas as something we've actually seen as just community members of our own throughout. So it's hard to say. There is no specific age range that I can say for sure. But I can also then say it is mostly adolescents, anywhere between the ages of middle school to younger. We do see a lot of those kind of behaviors during like baseball games, softball games, just because we are very also large county known for Bodeg Fest. So it's a very cultural appropriate thing right now.
Thank you, Ken. Yeah. Other questions?
Lena, so the data that gets put into the registry, is it from where like their biopsy is tumored and the diagnosis of that county or the county where the patient lives?
So we have we have address at diagnosis, so that we do have a residence at the time of diagnosis. We also do have reporting facility information. I feel like that is both of these pieces of information, I think, are treated with a lot of care in terms of what we release. So data that you'll see presented on like WISH or ECHT, those public portals, were using their residence, the person's residence, for their county, at the time that they were diagnosed. But yeah. Are there other questions about? There?
David, we have one back.
Hi, I really enjoy the presentations. I'm just curious, I mentioned a couple instances of, I heard key informant interviews and getting sort of community feedback about this. I'm curious how you integrate qualitative research techniques, like things like key informant interviews and focus groups and these methods in sort of how you get meaning from the quantitative data that you've collected.
I can start off and pass it off to others. I know with some of the work we've been doing in like the state health assessment and state health improvement planning, a lot of the themes and priorities are really based on direct community conversations with other partner agencies and with, you know, community members themselves. And then we often use that to drive our work and then support those themes that came out of community voice with some more quantitative data. Sometimes we need a quantitative data point to, you know, fulfill a grant requirement or fulfill a plan requirement. And if we add in that layer of quantitative data, we can also be able to track some progress over time. I know with a lot of the areas we're moving towards working in social determinants of health, we don't often have the perfect quantitative indicators for those elements as well. So it really is that balance of the mixed methods approach, drawing on those qualitative findings and supporting where we can with quantitative data and also noting the limitations of that data as well.
I think you stated that perfectly. Yeah, it's a very good mixed method. We definitely use our key informants and our focus groups to initially drive the themes in our county, specifically just because it is primarily and currently happening when the secondary data is more past collection. But using that secondary data as a support to the primary data to help us just continue our work is very important in our direction of care. So.
I have to pick on Gail because she picks on me, but the cancer registry is under the same CDC grant funding as the Wisconsin Law Women Program. Gail Johnson, the amazing director, the Reducing Breast Cancers Disparity report that's on the Cancer Collaborative's website. Gail, this was before my time in the registry, but I still sat next to a lot of work went into planning. I guess, was it a summit of its own? Community engagement event, yeah, with a lot of partners on CW, but most importantly, breast cancer survivors. And I'd like to think that report and the data in it were primarily driven by conversations that happened with people in their lived experience. So, yeah. Hope to do more of that work in the future.
Other questions? Other calls for Gail?
I'll leave Gail alone. And this is easy. Is there a slide that has like an introduction just so we can try to remember like basic information that we heard? I love this kind of intro.
It's not here, or is it in the book?
Oh, sorry, if you go all the way back, there will be a slide. Yes, they will be. Okay, so the question was, first, can we just like see the wonderful panel members? This like they're gonna end, we're gonna end with their pictures. If you want that.
The other question was, are slides going to be available? Yes. So I don't think we mentioned that yet today, but we are recording the main presentations. So that will be available on our website along with slides and information we share today. So that'll all be available in the document. So we'll post that. So David.
So thank you, Pamela. One last round of applause for our panel.